And from my side, can you hear me?
Yes.
Okay. And from my side. Okay.
Hello, everyone. Welcome to our Zoom meeting. Today, we will have different topics in our agenda. Dr. Shumaila and her team will be presenting these topics. And before we start, I would like to welcome Dr. Sulafa to this meeting and would like to have her perspective, her experience, and her tips. Welcome back. Thank you so much for having you here. Thanks.
Okay, thank you so much, Dr. Nader. Hello, all. I wish you all the best in your journey and good luck. And I would like first to thank Dr. Nader. Matching the residency cannot be done without him. I have many experience from the geriatric research. I've done 3 research. One of them was oral presentation in Arizona, and attending the lectures. I'm so sorry. I have a network problem today. Can you hear me?
Yes.
Yeah, I'm so sorry for that. So participating in the telegeriatric helped me a lot in the process of matching, for example, attending the interview session, participating in the research. That empower my CV a lot. And I remember during 2 of my interviews, they asked me, they were so interested to learn about the telegeriatric research, what have gained through it. So when you put it in your CV, I'm sure many of the program will ask you about this experience. So just show whatever you have done. And so maybe a little background about me. My name is Sulafa Elhassan. I was born and raised in Sudan, and I graduated from medical school there. I practiced medicine in Sudan and Saudi Arabia. And I moved to Denver, Colorado in 2015. And I would like to mention this. So 2004 graduation. So for any all graduate here on the call. Okay, I'm so sorry really for the problem from my side. So for any old graduates here, do not give up. Do not think, okay, this is the end of the world. So for me, I'm 20 years, my graduate 20 years ago, and I could match. So just do whatever you can do. Do step 3, this is a bonus for matching. Do research during your participation in telegeriatric. This is also a bonus, especially on those who are interested in university programs. So I got an interview from University of Colorado, which is great program, and they look for research experience, this kind of thing. So do whatever you can just to maximize your chance to match. Also, any job that will let you have that interaction with the patient. For example, MA jobs. I did abstraction job like data entry. Also, I'm so sorry. Okay, can you hear me? Okay, thank you. So yeah, So any jobs that give you interaction with the patient, go for it. And also having clinical experience, especially hands-on experience, will be so beneficial. So I've done clinical rotation with with Denver Health in a program called Colorado Work for International Physician. Now also the application is started, but just one of the requirement, the applicant should be living in Colorado for at least 2 years. So for anyone living in Colorado for 2 years, please feel free to apply for the program. It is 9 months hand-on clinical experience. And also one of the tips, personal statement writing and CV, and try to have many people who can review them. So English is not our first language. We can make mistakes, and having like another eye on your personal statement, your CV will help a lot to empower your application. This is one of the tip, and also doing interview. So um, I think, Dr. Nader, you always started the interview practice maybe by September. So yeah, this will be so helpful to attend here and try to present there. Sometimes I feel hesitant. Okay, not ready, but yeah, we are all learning here. Just go and talk in front of people, small groups, even sometimes like I can translate to Arabic to make interview practice with my family. So do whatever you can, as much practice do you want, and I wish you good luck for all. This is just quick tips, and please, if anyone have any question, feel free to unmute yourself. And yeah.
Thank you so much for sharing your experience and tips. Any
Sure.
questions for Dr. Sulafa? So it's a good idea to start, as she mentioned, working on your interview skills. You can start that with just a little bit of the common questions. Tell me more about you, or why did you choose this specialty or this area or this program, and so on. So few questions, you start building your answers, and try to practice that with your family, your friends, and anyone that you can catch in person or virtually, just to practice and start building your confidence level, and see how you can manipulate your answer. So thank you.
Sure, thank you. Yeah, exactly. Like whenever you practice, you will feel confident over or over. Like don't memorize the answer, like because it will be like very clear to the person who interview you. For example, at beginning, I try to memorize the answer, and then I video record myself, and I found it, yeah, it's clear, like it's something I memorize and practice a lot. So start to rephrase any sentence you put only on bullet point and just rephrase them time by time and time. Then you can build the confidence and yeah, go from there. And as Dr. Nader mentioned, start with the basic. I remember I have like 10 pages or 12 pages of questions that I start to answer. And then none of them, like in my interviews, I have been asked for. So the basic is so important. Tell me about yourself, why you're interested in family medicine. I'm sorry, like the internet connection today. So uh, poor. So yeah, so practice those questions that is like heavily asked in the interview, and then after you like write it, practice many times, you can add more. So like there is someone also can be asked with different things. So no one now will ask you what is your weakness. So they might ask you area of improvement or what challenges. So know uh, how this question can be asked and prepare your answer. May like develop like mini story, because you cannot say, okay, if they ask you what is your strengths, you cannot say I'm team player, problem solver, great in communication skill. This is not an answer because you don't tell them like the full story. So make example for each question. What is your strengths? I'm team player. I can work with people from diverse cultural background, and start to tell the story about this. I'm team player. We were in, for example, ED department. We have a big car accident. We do so and so and so, and mention like there is a start technique. Okay, so sorry again. So there is a STAR technique you practice answering your question with this STAR technique. What is the situation? We were in the ED and this happened, car accident or food poisoning in large group. And what is your action? What happened? Okay, we work as a team. I was on that floor. You can be a leader or just team member. Like it is not necessary. I was a supervisor. I like divide the role between the each. So any simple thing that you do and just like describe it, what is the action you do and what is the accomplish and result, any debrief, like you feel you do good in that, and that um, result of the thing that you are doing. So just describe all of that and then go to the next question. Okay, I can see there is some question in the chat. Okay, so there is one question, how many programs? Okay, so try again. So how many programs that it's really like not a number, just like it depends upon many factors. For example, how many specialty that you are interested in. So family medicine and internal medicine. And you will find if you apply to 80 program in internal medicine and 80 program in family medicine and like 40 family medicine, 40 internal medicine, this will be little cheap. It will be cheaper than applying one specialty. But also that you can decide this according to the interests. For example, for me, I like both. I like internal medicine, I like family medicine, so I apply to both. And I applied to 84 programs. I got 5 interviews. I'm sorry if this happen again. I will try to change the room. Maybe I will find better connection in other room. So yeah, so that depends on many factors. One of them, like how many specialty do you are you interested in, and also you filter. Like I remember we had a group last year. We made like Excel sheet. We literally is make scanning for each state. what program are IMG friendly? Like we never apply for a program for zero IMG because our chance will be less. The only exception we have made for Colorado, because now Colorado started uh, to accept the IMG. Before, like it's very like 1 to 2% IMG in the area, but now they the program started to accept IMG in their program, so just this is exception. But then at that time we skipped.
So one thing I just want to add, and you can continue, Dr. Sulafa, is in the WhatsApp group, you can approach in the big group, see if there is a list that can be shared between you guys with IMG friendly. That might be helpful. And please feel free, Dr. Sulafa, to share that list or sheet with the group or in the WhatsApp, or if you send it to me, I can add it to the app. Thank you. Go
Sure,
ahead.
sure, yeah, thank you. Yeah, so and make the updated one because really it differ from year to year. For example, the requirement and if try to update one. Like we had a list, but we built on it because we search from Frida, we search from other website that shows like the characteristic and requirement prerequisite for any program. So just try, even if you have a list, to try to double check this list and update it. Like make a small group or large group, whatever you feel comfortable with, and start.
So in the app, you can find groups that are interested in certain specialty like IM or family medicine. So you can join this group, or you can contact some of the fellows in the area where you live, and then you can also help each other. Let's say I can see I'm in Michigan and there are 4 fellows here in Michigan. Maybe we can work together to update the list that Sulafa shared, for example, on all programs that in Michigan. And this list will be useful for all of us who lives in Michigan, for example. Go ahead, Dr. Sulafa.
Yeah. And I can see there is question about as IMG from banned country, should I apply this cycle or wait until further change? So like this is really unfortunate, but maybe you can do small application like maybe with 30 program, but really IMG friendly program. And like hopefully by that time, like there is resolution. I know now, like many of the organization I changed the room, maybe that's will. Oh, so yeah, maybe by that time, like everything will be like going better, like for the IMG. Another question: what about year of graduation? Should we not apply to any program? So I've applied to programs that accepted only 5 years, and I receive interview from those. So like it is not a rule, but try like to make priority to the program that accept more than 5 year. If you are more than 5 year, then if you are more than 10 years, apply to the. Okay, sorry again. So yeah, I will see if there is any other question on the chat. I'm sorry, guys. Like I take a lot of
If
the
you don't
time.
mind, Dr. Sulafa, can you share your email in the chat so that
Yeah,
if there are
sure.
more
Yeah,
questions, maybe
sure.
people will reach out
Okay,
in
sure.
If you have questions, please raise your hand or use the chat or jump in.
And just keep the hard work. Like try, as I mentioned, this is step by step. Do not put yourself in a lot of stress, especially in the interview season. If you want to study for step 3, do it beforehand. Like interview season, try to focus only on the interview season and go to the interview in relaxed mode. Like do not panic or like put a lot of stress on yourself, and you can do this and you got this.
Thank you so much, Dr. Sulafa, for sharing all these tips and your experience with us. And
Sure.
July 1st is the day for you,
Is the start there?
the starting day.
Yes, I started 2 weeks ago with the orientation,
Presentation.
but I will have my first patient on June 30th.
Okay.
Yeah, so I have two
Wishing,
weeks of that, yeah, orientation.
wishing you all the best, and
Oh, thank
keep
you,
us
thank you a lot.
posted and let us know if we can be of help. And one thing I want to ask you, it might be difficult the first year, but the second year you might be able to. If you have interesting cases or if you have some topics for research projects, ask your seniors, or maybe you can come up with some ideas and share it with us. We have fellows who are interested in performing some of these activities like the research. They have the time, and we just are looking for some ideas or some cases or something that we can, it's going to be beneficial for you. You don't have the time to sit down and do the research part, as I know first year will be clinically demanding for you guys, and it's good for the fellows here in the
Sure,
fellowship.
sure, I will. I know like they have many quality improvement projects, and I will share like whenever I got like idea or for example data that we can start with, I will contact you and we can create a small group to work on that. And if I got many projects, as many group we can participate. And thank you for that, Dr. Nader. It will be so helpful.
Thank you so much. And, we wish you all the best, and thank you for coming over and sharing all this
Thank you.
information.
And really, I'm sorry for this network issue. And good luck for all of you. And thank you, Dr. Nader, for your help and support throughout my journey.
Thank you, and we are very glad for you and wish you all the best. Thank you, everyone. Now we will start with our agenda item. So the first presenter will be ready. When you are ready, you can share your screen and go ahead. Dr. Shumaila, you can moderate the meeting from now on. Thank you.
All right. Thank you so much, Dr. Nader. So the next presentation will be from Dr. Olivia, Dr. Usman, and Dr. Saber, and that is the pain management in geriatric people.
Hello, good afternoon. Hello, hello.
We are here.
Can
We are
you-
here. We are
Okay.
here. No worries. We are here.
Okay. So the topic is pain management in elderly patient. Can you see my screen?
Yes.
Okay.
Yes.
So the first slide shows the approaches and challenges and the best practice. So so I will be talking about the pain management in elderly patients, as it is a growing concern as our aging population increases. The presentation is a collaborative effort with the Dr. Usman, Dr. Shabir, and Dr. Shumaila. Zafar, thank you so much. Okay, so come to the next slide. So why is pain management important? Pain management is
Can I
crucial.
suggest, excuse me, Dr. Olivia, can I suggest to use browser or the presentation mode instead of the slide deck? Thank you. If you go to the lower part of the screen to the right side, there is a icon there for presentation, like the second icon or something at the bottom.
At the bottom.
Yes, down a little bit, yes.
Down, yes. So, okay, so I have to little bit this. That's what we are saying?
Go to the left side a little bit. One of the icons here, yeah. One of these icons is presentation.
This?
I think this, yeah.
Okay. So approaches, challenges, and the best practices. The second is why is pain management is important. The pain management is crucial as it directly influences the patient's quality of life and overall well-being. Untreated patient can affect the daily activity and disrupt the social interaction, which often lead to increase the healthcare utilization and decrease the productivity.
Sorry, Olivia. Sorry to interrupt
please.
again. We're still on the view for the slides. So if you don't mind, I want you to unshare your screen. And then when you share it again, go to the presentation.
Okay, I unshare and now sharing.
You can share,
Okay.
but now you can select the screen that has a presentation.
Share screen. It's in green color, right? That's what you are saying? Okay, I shared it. Right.
Or share the window.
Is that okay?
Yes. Thank you so much.
Okay.
Okay. So we are, as I was talking about, why is pain management important? Because pain management is a crucial in elderly people, especially because it affects the quality of life and overall well-being. Untreated patient can lead to daily activities, healthcare utilization, and their decrease the productivity. So pain management strategy help to mitigate and morbidity and mortality associated with pain treatment. 50 to 80% elderly people globally affect the this pain management problem, especially the chronic pain. So pain often underreported and undertreated. So that impact the quality of life, mood, and sleep mobility. The next slide is, what is the common causes of pain in an elderly? So first is musculoskeletal, neuropathic, cancer related. So musculoskeletal is osteoarthritis, osteoporosis, and spinal stenosis. The next is neuropathy that from the condition like diabetes, neuropathy, and post-herpetic neuralgia. Then third is the cancer-related and post-surgical injury-related pain, visceral pain from the constipation, urinary retention, often overlooked in elderly. Next is, I'm sorry, I don't know how to do it. Okay. Next is the aspect of the pain management significance and what is the outcome. So first is untreated pain. So it leads to impair the function as we discussed earlier and decrease the quality of life. Next, and that increase the depression and risk of falls. Second is effective strategies. So this is a little bit blurry pictures, but they in this picture they are talking about the safe and the successful acute pain. This is the house pillar diagram where they are talking about the pain management approaches. So effective pain management stand on the 4 pillar. First, they are talking about the scheduled multimodal analgesia. Second, the opioid therapy when we need it. And third is the individualized treatment plan. And fourth is the managing chronic pain long term. The foundation is actually related to the patient-centered, evidence-based, and the consistent approach. So the next slide is talking about the pain in elderly. See, there's a two type, the noxious stimulus and the acute pain. In this picture, they said we have elderly people feel pain differently. Maybe they are less sensitive to heat, but more to mechanical pain. We can see in the left side where they are talking about the less sensitive to heat evoke pain, maybe more sensitive to mechanical evoke pain if there is a noxious stimulus. And the next, they are talking chronic pain diagnosis. So there is a superior pain acceptance and the self-efficacy with the less catastrophic levels. Peripheral and the central sensitization can, another point is the higher anxiety level it leads to, and therefore patient's depression and the sleeping time is worsening. Suppose if the patient having acute pain, in this, the pain perception is decreasing, pain threshold is increasing, and sensitivity to even in the mild pain can lead to, or maybe this mostly seen in the post-operative pain, or maybe patient may have a cancer pain, or either patient are suffering from peritonitis. Persistent pain, poorly tolerated, or maybe they have a progressive worsening symptom. Decreasing the pain unpleasantness, that is mostly the caregiver, family member, distraction, maybe sedentarism or dementia. That lead to the pain, decreasing the pain unpleasantness. Next, in the next picture, they're talking about the, 1 second, breaking the cycle of pain. So patient with the pain often feel that pain causes more pain. You can see in this picture, this is a pain experience where the pain can become a cycle. Pain leads to anxiety and inactivity. We can see the right side, and the brain changes, and that causes the more pain. And the research shows the medications and injection alone are not enough. So multidisciplinary care break. They said multidisciplinary care break this loop, treating both physical and the emotional aspect. So addressing the pain early can stop the cycle from the worsening. In the next bar graph, where the aging population growth, we can see here, over the 65 years old will rise from 7.4 to 16.4 by 2015. In 1996, where in world, they have only, 1 second, I can't see here. This is little different. Air only around in the world less than 10%. Where in 2006, it in the world it is still stable, but in the more developed country it has increased, not much but little bit. But by the 2020 for 50, it will goes up to around more than 25. So bottom line is that in this picture, from 7.4% in 1996, it can reach to 16.4 by 2050. More elderly means more chronic pain. So effective pain management is necessary. So what are the barriers we can see in the pain management? So barrier is first is the cognitive impairment, mostly in dementia patient. Maybe they have a fear of addiction or maybe side effect of the drug. Maybe they have a, underreporting due to the stoicism and polypharmacy concern because they already have been on many drugs. And last is the sensory deficit. Maybe they have a problem with the hearing or maybe vision problem. So next in this picture, they are talking about what we see in when the patient having acute pain. So in this picture, we can see there is in acute pain and there is a chronic pain. So here is that in the chronic pain cycle, the chart shows how the chronic pain lead to the poor sleep. You can see there's a poor sleep lead, the more pain, patient maybe have a more pain, and there is a mental health issues. This is a more pain and the more mental health. And when the patient have a acute pain, that is sometimes we can manage with the drug, but the chronic pain where since the patient already has been suffering from for the long time, so it can predispose to the sleep issues. So this cycle shows that the quality of life, such as we can see there is an anxiety problem, depression, this, and the loss of function is associated with the chronic pain. And it also shows that the early and holistic pain treatment is necessarily the patient having pain. So this is the next is the pain assessment tool. So they are talking about, we have a verbal descriptor scales, VDS, and numeric rating scales, and the faces pain scale. So zero, as we read it, the verbal rating scale, we have a 0, no pain, mild means little bit, moderate, severe, and extreme pain. Visual, when you can see from there by the facial expression, maybe no pain or worsening pain till 10 points. And numeric pain intensity, when the patient will be asked, what is the pain score 0 to 10. And facial, as the patient who are not able to speak, we can make it out by the looking at the facial expression. So this is these for dementia non-verbal patient, we generally use either faces pain scale or maybe pain, PAIND. That is a pain assessment in the advanced dementia patient. So this is what the non-verbal dementia patient. Observation of the non-verbal cue, facial expression, look for the missing, frowning, wrinkled forehead or tightly closed eyes, vocalization, paying attention to moaning, growing, signing, or other sound that may indicate discomfort. Then the body language, we observe for the tense muscles, restlessness, gardening of a body part or pulling away from touch, and consolability, that note whether the patient is easily comforted or remains agitated. Okay, I hope my turn is finished. Dr. Usman can continue. Hello? Hello?
Okay, I'm waiting for Dr. Usman.
I'm here. Assalamu alaikum,
Welcome.
everyone. Thank you, Dr. Shumaila. Thank you, Dr. Nadir, for having us here in this nice group. My name is Mohamed Osman, and I'm going to talk about the management strategies and plans for the pain management in elderlies. So, in general, we treat elderlies in two ways: the non-pharmacological intervention and pharmacological interventions. And we are going to discuss each one in separate module. Can you go to the next slide, please?
Yes,
So,
wait. Let me. Okay.
sorry, what did you say?
No, she said, I'm going to the next.
Okay.
Yes,
Go ahead.
So to have a good insight about how to treat the patients, we have to have like a pain assessment conclusion that need us to have a good history by interviewing the patients impersonally or interview proxy report. We have to do well reported physical examination, and we have to take a look at the test results. We have to assess the patient functional status, situation, constitutional variables, emotional status, and how the patient is reporting the pain level. And as Dr. Olivia talked about how to assess the pain level before, so we can use these assessment tools to understand the pain situation. And we have to assess and observe the pain assessment. If you can go to the next slide, please. So we usually start with non-pharmacological management. That include physical therapy and exercises, including stretches, mobility training, improve function, and reduce pain. And it's also work in enhancing overall well-being of the elderly. CBT, cognitive behavioral therapy, help patient developing coping mechanism for the pain management. It also helped its psychological impacts. Other therapies like heat or ice massage, acupuncture, and other complementary therapies offer pain relief and improve the quality of life. We have also the occupational therapy, home modifications. Usually the occupational therapy taking care of the, like, try to improve the patient functional inside their homes. Yeah, so they do the home modifications, taking care of home environment to improve the safety and accessibility of the patient during for his daily life activities. That include like installing grabbing bars inside the home, cabinets, ramps, helping senior aging in place. Assistive device to reduce a pain, like a. Can you go back?
I'm sorry,
please?
I'm sorry, I'm sorry.
No.
I don't know. Wait. I don't know. It
No
clicked
problem.
and how to go back?
If you can press the up arrow on the.
That's the problem. I don't know how to use.
You can stop sharing and I can share from
I'm
here.
not able to go back.
Okay, Dr. Olivia, you can stop sharing. Dr. Usman has all the slides. He will share it. Thank you.
Okay.
Dr. Usman, you can share.
Yes. I just need to do some change here in my privacy setting before I will be able to share my screen here. Dr. Shamila, can you share the screen? I have some problems here with my.
Okay, Olivia, again share the screen.
Okay, wait.
Dr. Olivia? Dr. Shahad, Dr. Shahad, you have the okay. She started. Okay, Dr. Osman.
So,
Can you see my screen? Hello?
yes, I can.
Hello?
Yes,
Thank you.
yes. Thank you, thank you.
So assistive device like a walker, reacher, dressing aid to make daily tasks easier and safer for the elderly patient inside their homes. And also you have to include the group therapies and its social support, often neglected but improve outcome. You can scroll to the next slide, Dr. Olivia, please.
I did it.
We are still on the
Can
previous
you see
one.
my screen?
We can see your screen, but yes, it's now moved to the next. Thank you.
Hello?
Yes, we
Yes,
can
thank
see.
you.
Thank you.
So in general,
Really?
physiotherapy help pain management and cure in such many ways, like during sport injuries, accident and trauma, post-surgery, geriatric physiotherapy, and chronic diseases. You can go to the next slide, Olivia, please. I think we lost Olivia.
Can you see my screen?
Yes.
Can you see?
Yes. Can you move to the
Okay.
yes.
You can go to the
Next.
next slide, Dr. Olivia, please. Yeah.
Okay.
So non-pharmacological management always is not sufficient. So we have to add or go for the pharmacological management. And usually most of the physician like do both of them at the same time. And the main goal here, especially in elderlies, is to start low and go slow. Like begin with lower doses of analgesic and gradually increase as needed. Usually, we start with 25 to 50% of the regular doses that adult has, and go increase the doses as you going on. And this is because we want to monitor the side effect and potential direct interactions, especially in elderlies. I think my colleague last week talked about the polypharmacy, and they talk a lot about the like different physiological change that happen in elderlies. So we have to be careful about all these changes. Older adult at higher risk for adverse drug reaction. So we have to monitor their prescription and adhere effectiveness and prevent overdose and adverse events. Empower your patient to work with you on this task. We have to educate a patient very well about the side effect of the medications and how to report it and when to report it. Educate and activate the patient to understand and report all medication-related problems. Include your patient in all decision-making about their care plan. So the patient will feel like he is part of his solution. Follow up on prescribing decision to maintain, change doses, change frequency, discontinue or substitute or add a drug. You can go next. So starting with medication, we usually start with non-opioid medications like acetaminophen, which is very safe, especially in elderlies, but it's not effective, especially if there is inflammation or joint swelling. So we will add like non-steroid anti-inflammatory drugs, but we have to be careful, especially in elderlies, because of the side effects like gastritis, peptic ulcer, GI bleeding, and renal injuries. So we have to keep monitoring on this side effect. Next. So this diagram will show us starting drugs, starting with acetaminophen. And as we are going on, we can add non-steroid anti-inflammatory drugs. We can add topical non-steroid or regional nerve blocking agents like analgesia adjuvant. We are going to talk about that next. And if all this not effective, we have to go to more deeper like ketamine. And finally, we can use opioid for moderate to severe pain. Next. Olivia. Dr. Olivia, are you here?
She's
Yes,
having
this is the next slide.
she's having
Yes,
internet.
next
Okay.
There you
slide.
go. So the second line will be the opioids, and opioids should be used cautiously for shortest duration possible in elderly especially, because increase the risk of adverse event. And that include respiratory depression. The most common is GI symptoms or side effects, including constipation, and also CNS manifestation like cognitive impairment. So when we start opioid, we will make sure the patient know all the side effect of the medications, and we usually the physician want to start like the patient on laxative to avoid the constipation on GI side effect, and we have to educate the patient about the side effects. Next, adjuvant medication, the FDA approved antidepressant and anti-seizure medication and muscle relaxant do not have an FDA indication for pain, but may be effective for pain management. So it's like a medication that is not for pain, but it has as a side effect of it. It can use it for the pain management. So antidepressant, we can use the duloxetine or disparamine. It very good in helping and relieving the neuropathic pain. Also, it helps with improving sleep. Anti-seizure medication used to relieve a nerve pain described as shooting pain, example like the gabapentin or carbamazepine. Muscle relaxants is helpful treating a muscle spasm and maybe sedating for some extent, like the baclofen. Next. So we have the peer criteria. It's like a list of medication that usually updated by the JSR, many associations. It has like many medications that should be not used in elderly. And most of them is pain medication, like the amitriptyline, indomethacin, ketorolac. non-steroid anti-inflammatory drugs long-term, like naproxen, mibridine, different kind of muscle relaxant, bentazocine, and propyxine and propyphenine containing products. Next.
Next is Dr. Shahd turn. Dr. Shahd Hassan. Are you there, doctor? Dr. Shahd?
Dr. Shabi.
So I'm waiting for Dr. Shahd actually. Dr. Shahd Hassan.
Hello?
Yeah, go ahead, doctor.
Okay. Hello, everyone. My name is Dr. Shahd Hassan, and I'm here, and I'm glad to be here for, to participate in this presentation. Okay. So, can you please go to the next slide? Hello?
This is the next slide after the Beers criteria.
Yes. Hello, so are you sharing the slides? Because I cannot see them.
Her net is coming and going. There is so much net problem going on. So
Oh,
yeah. So just give her some time, like
Wait,
1 minute.
wait,
okay, you
wait,
should take your
wait.
time.
Sharing my screen. Wait.
Okay, thank you. Go ahead, doctor.
Can you see my screen?
Yes, thank you.
Yes,
Thank you.
I can see it
Can
right
you
now.
see my
Thank you.
Yes,
Yes, I can see
thank
it.
you, thank you.
Okay, Dr. Olivia, if you don't mind, can you go to the next slide?
But we haven't discussed this slide yet. We have.
I'm so sorry, I can hardly hear you.
Start from this slide.
Um,
I am telling. Okay, I'm telling you, your turn start from this slide. Because Dr. Osman didn't speak about this slide, so you have to say. You understand me?
okay, I don't mind.
Are you
So,
getting my point?
yeah, I can hear you. Okay, so we're gonna be speaking about older adults with chronic musculoskeletal pain. Okay, so we have different aspects of management. We can actually focus on, we can start with the lifestyle changes like exercise, walking program, weight loss. Okay, and then we can proceed further to involve the psychological and the behavioral part. Okay, which involves going to psychotherapy, group support, and coping skills. And we can then involve the physical therapy and rehabilitation, which can involve physical therapy, occupational therapy, assistive devices, and there is a part of complementary, alternative, and mind-body approaches, which can, for example, there is acupuncture, yoga, tai chi, and mindfulness. And there is the pharmacotherapy part, which involve medications, pharmacological medications like oral and topical analgesics. And we can have some sort of interventional approaches, which can be either by injections or which can involve surgical part. So this is like the extreme type of management. For example, total knee arthroplasty and total hip replacement. Okay, so can you go to the next slide, please? Okay, so we're going to be talking about manual therapy for elderly patients. Okay, so it includes a variety of hands-off techniques that's performed by trained practitioners, such as a physiotherapist or an osteopath. And the aim of these kind of managed therapies is to reduce pain, improve joint mobility, and promote circulation, support physical function and balance, for example. As an example for these therapies, there is massage therapy, joint mobilization, manual stretching, and acupuncture. And if you don't mind, can you go to the next slide? Okay, so we have this diagram that include 3 types of domains. We have prevention, which is avoiding the pain before it starts. So proactively, we're preventing the pain before the surgery itself. Okay, and we have restoration, which the aim is to restore the function and to reduce the existing pain. Okay, so it's interconnecting both prevention and palliation. And the third domain is palliative therapy or palliation. The aim is to comfort, it's like more of a comfort care, especially if the full recovery itself is impossible. For example, in terminal illnesses. And we have 3 R's here. So the firstly, it's culture of pain management. It's more of creating an environment where pain management is taken seriously by all the staff, okay? And we have the equitable treatment to ensure that all the patients in the hospital setting, regardless of the background, get fair access to effective pain management. And we have the sustainable best practices, which is measuring the outcome and improving it continuously. Okay, so can you please go to the next slide? Okay, so here is the figure for the Kolkabis dimension of comfort. So comfort isn't just about physical, it isn't just physically, we have other parts as well. So physically, which can involve the manual therapies that we talked about before, or medications. And we have the psycho-spiritual comfort, which is basically helping the patient to cope emotionally with the chronic illnesses. And we have the environmental part, which is, for example, adjusting the bed or room lighting for comfort. And we have the socio-cultural comfort, which can involve family care planning and respecting the patient's cultural beliefs. And can you go to the next slide, please? Okay, so usually elderly and all the patients in general are treated by the multidisciplinary approach, which is collaboration between physicians, nurses, and psychotherapists and psychologists. And it can also involve caregivers and family, which is making up a team. And they regularly assess and modify the treatment plan for the patient. Can you go to the next slide? Okay, so the management itself, as Dr. Osman earlier mentioned, involve both pharmacological and non-pharmacological strategies. And just briefly, non-pharmacological strategies can involve physical therapy, cognitive behavioral therapy, complementary therapies such as acupuncture or meditation. Okay, and this is important because it helps to regularly assess the patient and ensure that the plan itself goes in a good way. And we focus on patient-centered approach that respect the preferences and the needs for each individual, okay? And there is a shared decision-making, which is basically a collaborative process that allows the patient and the healthcare provider to make the decision together. So we take the account for the best clinical evidence available from the doctor's side, as well as the patient's value, preferences, and circumstances. So can you go to the next slide? Okay, so here are some examples for non-pharmacological therapies. And we have the music therapy, which helps in reducing anxiety and improving mood. And it's proved to be effective. We have relaxation techniques, more like mindfulness or breathing exercises, which can alleviate the stress. And we have the spiritual support. And we have the aromatherapy, which is basically using essential oils in managing the patients. Can you go to the next slide? Okay, so here is just an example. We have an elderly woman with osteoarthritis, and she has mild cognitive impairment. Her pain level is 7 out of 10, which is affecting her sleep and mobility. So we first start with physiotherapy and paracetamol, and then we follow up during these 3 weeks. And if the pain did not improve, we can add duloxetine or tramadol to her management. And the next slide. So this is an example for a graph that is used to for follow-up for the patients. And yeah, this is the graph that shows the results throughout the weeks. Okay, it shows the progress of the management plan. Can you go to the next slide? Okay, so here are the summaries of what we talked about in this presentation. So we shouldn't just assume that just because this patient is an elderly, it's normal to have pain. We have to actually search for the cause or the origin of the pain, because it might be something serious. And it's usually assessed using tools that was mentioned by Dr. Olivia. And we have the multimodal treatment. We have different type of treatment that can involve pharmacological and non-pharmacological parts. And we monitor for side effects and functional improvement. And of course, the management itself improved the multidisciplinary team and caregivers. And just as a reminder, we have to focus on the patient, not just the pain score. So thank you so much for listening, everyone.
Thank you so much, Dr. Shahd. And the next presentation is Dr. Samaher, and she's going to present the step designing in effective research poster and presenting finding at the conferences by using the Canva. So I hand it over to Dr. Samaher.
Assalamu alaikum, everyone. Is my voice coming through clearly?
Yes.
Yeah. My name is Samaher Taj Eldeen. Currently, I'm a medical doctor in Ireland. Thank you all for being here today, and thanks, Dr. Nadir, for your constant guidance and support. And thanks to Dr. Sulafa for sharing your experience, if you're still here, and thanks to my team as well. I'm delighted to have a chance to present my second presentation here, and I hope you find at least one useful tip in this talk. Well, I'm going to present how to design an effective research posters. I'm not a poster design expert. In fact, my first research poster was a struggle. I remember I spent hours wrestling with the formatting. So maybe today I can save someone else the headache. It's an important topic, especially for busy medical professionals, and the research posters are not conference decorations. They are well-deserved recognition of their hard work. It's like a good ECG, clear, concise, and tells you what matters. That's why it plays a great role among researchers. So let's dive in the essential steps for effective poster presentation. This presentation outlines the key steps necessary for creating a compelling research poster and effectively presenting findings at conferences with the focus on the needs and interests of the medical audience. It's very important to understand the purpose of a research poster. In general, the poster are visual medium to present key information at events. It communicates complex information, facilitates audience engagement, and encourages networking opportunities. The primary goal of a research poster is to effectively convey complex information in a visually appealing and easily digestible format, targeting specific audiences such as medical professionals. And posters serve as a point of discussion, allowing for interaction between presenters and attendees, which enhances understanding and interest in the research topic. Effectively designed posters not only summarize research findings, but also invite questions and foster networking opportunities among professionals in the fields. There are key elements of an effective poster. The clear title, the concise abstract, engaging visuals, and well-organized sections. A clear title captures attention and conveys the main topic at a glance, setting the stage for the audience's understanding. And we know that to form an abstract, we need to answer the questions: what, who, how, when. And the concise abstract summarizes the research question, methods, result, and implications, providing a quick overview for viewers. Engaging visuals such as graphs and images enhance understanding and retention of information and drawing viewers in. As you can see, this poster has no visuals, so it's kind of boring and not drawing viewers in. And then the well-organized sections aid in the logical flow of information, making it easier for the audience to follow and comprehend the content. They are effective design principles, and at the same time, they are consequences of poor design. Effective design principles enhance readability and engagement in research posters. Utilizing a readable font size, at least 24 points, ensures that text can be easily viewed from a distance. Additionally, a strong color contrast between text and background improves visibility and captures attention, helping to convey the message more clearly. On the other side, poor design choices, such as small font sizes below 18 points and low color contrast, can create barriers to understanding. These elements may lead to confusion and disengagement as the audience struggles to read or comprehend the content. It's vital to avoid overcrowding in the poster with information which can overwhelm viewers. I do believe that the research committee or the, for example, the poster exhibition committee, they usually put guidelines and advice on poster preparation, or they usually put instructions. For example, they can put specifications and printing. They can say the poster must be A0 size, for example. Of course, that's after when you submit an abstract. After acceptance, they send you the instructions to form the poster. And they can also, like, sometimes they decide on the color of the color, if they have like color code. So you need to be careful and to follow these instructions and guidelines. So using Canva for poster design, we will walk through the step-by-step guide to creating effective poster using Canva's features. The first one is selecting a template. You need to choose from a variety of professionally designed templates tailored for academic and research presentations. And then you can customize the design, edit the text, the images and colors to align with your research, content and branding requirements. After that, you can add visuals and graphics, incorporate graphs, charts, and images to make the poster visually engaging and informative. And finally, you can finalize and download, review the design for clarity and coherence, then download the poster in your preferred format for presentation, whether PDF or photo. Engaging your audience during poster presentations. An effective poster presentation requires not only a well-designed poster, but also the ability to connect with the audience. Presenters should focus on clear communication, summarizing key research insights, and inviting questions to poster discussion. So I'm sharing with you my poster on clinical audit. I participated in Sligo University Hospital about 1 month ago. I didn't win any awards, but it did grab a lot of attention from the audience, which was exciting. And interestingly, I used Canva. So I will share with you my experience on the steps. So now we're going to use Canva. First, just recap, we need to choose a template. We start by selecting a suitable template from Canva's extensive library that aligns with your research topic. And then we customize the content by adding like our research title, the author names, institutional affiliations, and we have to ensure that text is clear and legible. And then we can add the visuals, graphs, images, charts, and we will finalize the design. So this is Canva. It's you can download an application or use the website. So first, you need to create an account. I usually have an account. But first we need to have an abstract. So I'm gonna use ChatGPT. Let me say like a topic, the importance of the telegeriatric research fellowship in among USMLE aspirants. I need just to give the ChatGPT an order. So please, I don't know why I ask ChatGPT with please always, like it's as if I'm dealing with a real person. So please create an abstract for a poster on the importance of telegeriatric research. Let's see. So yeah, so in general, after you've done with the abstract, usually you put the format or the content structure, I would say. So at the top, you put the title, the authors and institutions, and then you start with the background or introduction, and then you put the aims and objectives. And after that, you put, like, I'm talking about the sections, and then you put the methodology section. And after that, you put the results, and then you put the conclusion, recommendations, and you may need to add action plan, action completed, and then references. And there is quite like, there's a difference between the research or the clinical audit. So it depends on your outcomes and your area of research. I need just to modify this. So please, the poster presentation. So let's see. So I'm not saying that we can ask ChatGPT for research, but I'm trying to get a format just to make the things understandable. For example, that's Canva. I'm gonna use just like an example. So we go to the home here. And then you can choose, like, there's poster, sheet, document, presentation, photo editor, for example, social media. Our goal is to create a poster. So here we go. You need to follow the instruction. Like if the research committee said, like, put the, they need like a poster size A0, you need to create A0, for example. I have a free version of the Canva, but still, like, you can subscribe and get more options, but still this is reasonable for me. So here, resize, you can choose the size, but it's fine. I'm gonna use this one. So we go to design. In the design, we can write a medical research poster, for example. And here we have a few examples or few designs. And then I'm gonna choose any one of the free examples here. I can use this one, and then we need to customize this according to our research. So for example, here, I need to change the topic. I will put here geriatrics, for example, fellowship importance. And then you can adjust the size also according to the guidelines. And remember that we said regarding the colors, we need to use high resolution color. And if we use like a light color on the background, we need to use a light color to the text. So here, for example, the color for the background is black, then we need to use a light color to the text. You can change the color. For example, this is black. You can select the area, and then here you can change the topic to white, for example, to blue or whatever. So back to the black one. And then here I put the topic. Below the topic, usually we need to write the the name of the researcher, and for example, Samaher Taj Eldeen. And then you can customize the introduction. You change everything according to your input. So here I can go to the telegeriatric curriculum, for example. I can put, for example, early research experience, as if I need this to be in my poster. So imagine I copy and paste it here. And I don't know what's happening, but it's fine. So just the idea is we need to customize the template according to our research. And then here, the statistic, for example, you can change that to background, for example. And here you can also change the input here. And for the chart, or for the you can change that here from the applications. Go to the apps here. Sorry, it's in the to put like a chart, you need to go to the apps and then choose charts. You will get a few options like line charts, bar chart, and then you can choose any one of them. For example, if I choose this one, I'm going to delete this one. And you can edit that, or it was free. I think usually they give like a few free trials, and then once you've done with them, you need to subscribe for the I just need to show you how you insert your data. Yeah, you can always like search what you want to get. So I just wrote like analyze the data. There is an option for Google Sheets. If you have the data, you can just put it in Google Sheets, and from here you can just download it from Google Sheet, and you will get the result here in a chart. For this one, after you put your data, you can change the colors. So here I can change the color of this one and this one, for example. So according to the poster itself. And so, yeah, that's it. That's the idea of the how you customize any template according to your research. I hope I made it simple and clear because it was difficult at the beginning for me, especially like I tried many applications starting with PowerPoint, and I found it like traditional and basic, and I tried to find new applications or so that's Canva is one of the easiest one, and you can just easy do this. Sometimes you can use there is AI tool like here Canva AI. You can write please give a template for poster for medical poster with for example 6 sections, and you just go, and then it's a conversation. Then you can speak with the AI and ask for whatever you want. So for example, you choose this one and then you start editing as well. So yeah, that's the whole idea of creating a poster presentation. And here are the conclusion and key takeaways. So you need to understand your audience, recognizing the target audience allows for tailored messaging and design, increasing engagement and comprehension. And also you need to focus on design. Effective design emphasizes clarity and ensuring that key information stands out and easily digestible. And practicing presentation skills leads to create confidence and better engagement with the audience during the presentation. I think this is my mistake. I think I needed to practice like I needed to put like a ready presentation on Canva before I just go with you randomly to create one. Like maybe you felt that I'm just going to ChatGPT trying to get some information to put it here and here. So if it was ready before, so it would have been better. So that's it. And if you have any questions, feel free to ask me.
Thank you, Dr. Samaher. That was wonderful. And now the next presentation is Dr. Malaz. And the
Yes, hello, assalamu alaikum everyone. My name is Razaz, and I'm going to talk to you about mobile apps usage in older adults. Just let me share my screen. Can you hear me?
Yes, we can hear you.
Perfect, thank you.
And we can also see your screen.
Awesome, thank you. Let me flip it. Okay. So everyone, hello. I'm going to talk to you today about research methodology and some researches about mobile apps for older adults. In general, we are leaning into a world that cannot live without technology, without cell phones, without laptops, iPads. Now we have smartwatches. There's a lot of parts in our lives that don't go through without having phones. And the older population is increasing. In the following years, we're going to have more and more of the older people now that the health sector is really evolving. So it is really important to make sure that even the older people are able to use the phones, they understand how to use them. And you know how the older that you get, that there is a possibility of cognitive decline happening. and things could get harder for you, even though in the past you were able to do them perfectly fine. So this is the idea. The researches that were made, most of them were trying to assess the quality of the apps out there in the stores. Can older people use them as well or not? Are they easily accessible for them? Are the designs clear? There were a lot of factors that were put into consideration. So, like I said, smartphones have become an integral part of daily life, not just for younger generations, but increasingly for older adults as well. As our population ages, it's critical that we direct innovation toward meaningful digital inclusion. Older individuals, especially those living alone, which happens a lot when, for some people, when they get older, they often face challenges related to their health, independence, and their social isolation. Technology, when used through thoughtfully, can help bridge those gaps. There's a growing need to develop and promote mobile apps that support older adults in managing medications, attending medical appointments, and staying mentally and socially engaged. And there's a lot of other reasons that I don't think we're going to have enough time to list, but it's really important to be able to use your cell phones. So it's 2025 after all. Digital solutions should be designed with all the age groups in mind. The same way future generations will navigate aging with technology at their fingertips, we must ensure today's older adults have the tools and support to do the same. So the methodological standards and frameworks that were used, most of the systematic evaluations in this domain adhere to recognized guidelines such as PRISMA, which is preferred reporting items for systematic review and meta-analysis, and ISO 941-10 for usability evaluation under the human-centered design philosophy. Sadoway et al.'s framework, which is a guide for doing literature review properly in research, reinforces a structured, reproducible approach to literature synthesis. Methodological rigor is maintained through well-defined eligibility criteria, example, inclusion of end-user testing, development evaluating integration, and robust multi-database search strategies. Example, PubMed, IEEE, Scopes. Selection and evaluation criteria. Eligibility follows the PICOS framework, which stands for P, population, adults more than 60 years old, interventions, M, health apps, excluding passive mobile interventions, like SMS or wearables without app interfaces. If the phone, like the old phones, the old Nokia phones, they're not going to be really helpful in these researches. Comparison, it's not applicable for me because I only was able to navigate through 5 researches, but of course there were thousands of researches about this topic, so I think it might be in use. Outcomes required empirical evaluation with older cohorts, study designs, peer-reviewed original research with development and usability phases. Quality is frequently appraised using tools like MMAT, emphasizing methodological clarity over outcome significance. Screening reliability is validated via inter-rater agreement metrics like the Cohen's kappa. Data collection and reviewer collaboration. Data extraction and quality assessments are typically conducted by at least 2 independent reviewers, often preceded by standardized training using like the MAR's SG training models, which stands for Mobile App Rating Scale, German. So it is a German method. Apps are downloaded and explored under real device conditions. So idea is you just don't use them, you just don't check the, let's say, the app reviews or check the app pictures in the app store. No, you would have to actually use them and try them yourself. And they did this in various devices. They did them in iPads and tablets. Even the iPads themselves, they used them in different screen sizes, like iPad mini, the bigger iPads, the phones. They tried multiple devices because apps looks different in different devices. They don't look the same. So it's important to keep that in consideration. It's also the fact that older people tend to need to have bigger screens. So usually they're going to be leaning into using phones that have bigger screens. To assess the functionality, is the app working properly or not? The aesthetics, how does the app look like? Usability and content relevance. Technical issues are cross-validated on multiple devices. Inter-rater reliability is measured using ICC. ICC is a statistical tool. It's an intra-class correlation coefficient, and it just measures how consistent or similar the ratings between others are. So there'll be a score between 0 and 1. They set a score, and in one of the researchers, they chose 0.75. So if it's the rating is 0.75 or more, that means that the reviewer is satisfied with the app. App quality assessment tools, we're back to the MARS-G, the Mobile App Rating Scale German. It is a validated instrument used across studies to rate app quality along 4 dimensions: engagement, entertainment, adaptability, functionality, navigation performance, aesthetics, the visual design, information quality, accuracy, credibility, and evidence base. Each item is scored on a 5-point Likert scale. Studies may also correlate MARS-G scores with user star ratings and privacy security indicators. Like they could use that in handy as well, the reviews that we see online. Categorization framework. We have the apps are categorized using frameworks like Kuhn et al. Classification, which includes functional types, such as protection and monitoring. So example, the emergency alerts, the drug reminders, water reminders, all of these factors. Training and simulation, cognitive games, and relaxation. Like I said, there will be a cognitive decline, so this would be really useful for older adults. Diagnostic support, symptom trackers, interface adaptation, accessibility tools like magnifiers. These categories facilitate targeted analysis of effectiveness across varying health domains. Design principle and thematic guidelines, evidence-based UI, UX recommendations. UI, UX is something usually used in computer science. So it's just the design of the app and how does it look like, the functionality of the app, and is it easy to use or not? That's the idea. Thematic analysis of usability tests, the Gomez-Hernandez et al. The Gomez-Hernandez was, they did a research where they actually went through other researches, and they saw the common problems that the older adults tend to face, and all of these researches combined. So the key guidelines that they included were simplify interface structure and minimize cognitive load. Don't make the apps harder to use for older adults and maybe even younger adults, because at the end of the day, some apps are actually really hard to use. So, but when it comes to the older population, of course, it's more important. Increase button size and spacing to accommodate motor decline. If you live with older people, if you have older people around you, you will notice often that they would ask you to like, please increase the font size. Can you make the app bigger? Can you make it like easier for me to see? So this is really important for them. Provide contextual health feedback and training modules, where you would check constantly with the older generations. Is the app really working for them or not? These insights are derived from interaction studies involving older adults, more than 60 years, ensuring ecological validity. Like I said, that was the Gomez-Hernandez research, that what they focused at. Real-world implementation studies. This is an example for a study that was focusing on real-world implementation. It was a randomized controlled trial with 181 older adults assessed the ESP app. ESP app is simply an app that helps older people. I think it's a Japanese app. I'm really not sure, but I think it's Japanese. It's an app that helps older people become more social and have more activities to do, which integrated self-monitoring, gamification, and feedback loops. Intervention versus control was the Google Fit primary outcomes. Step count and social participation analysis. And COVA is a framework that used for healthcare apps to assess them. And linear mixed effects modeling revealed significant improvements in the intervention groups. Such trials underscore the translational value of rigorous methodological design in mHealth research for aging populations. The summary of the methodological trends. Across systematic reviews and trials, 3 features stand out. First, integration of SCD across design phases. Secondly, empirical grounding of design recommendations. Thirdly, multi-dimensional outcome assessments, UX plus clinical efficacy. This convergence reflects maturing field that balances user-centric design with robust empirical validation. There remains need for more longitudinal studies measuring behavioral and clinical outcomes, greater inclusivity for culturally diverse aging populations, increased validation of design guidelines across apps categories as mHealth becomes a staple in the geriatric care. I think there is still a lot to work on in this part of the of technology in general. I don't think that the apps are geriatric friendly yet. I think there will be a lot of work to be done. I think also the older generations are gonna have it better, but I think in a few years where people could actually really focus on that, where I think when Gen Z get old, this is gonna be amazing for them because there will be a lot of apps that could support them, support their lives, and they'll be definitely easier to use. These are the resources that I used, and yeah, that's it. I hope that you found this helpful. Thank you for listening.
Thank you, Dr. Razaz. It was wonderful. Now the next presentation is with Dr. Malaz, that is the DVT prophylaxis, and Dr. Rana.
Hi, everyone. Thank you, Dr. Shumaila, for moderating this session, and thank you, Dr. Nader, for having us today. So, Dr. Rana and I are going to go over the clinical guidelines made by the American Society of Hematology for the management of venous thromboembolism, particularly in surgical hospitalized patients. And just let me share my slides first. All right, hopefully you can see my slides now.
Yeah, we can see them.
All right. So I will start by giving a brief introduction on why developing these guidelines was super important. Basically, as we know that healthcare professionals are working in a time-pressured environment, and at the same time, they need to make high-quality, evidence-based decisions whenever they are confronted with a clinical question. So they need trustworthy recommendations and to feel confident enough that they're taking good care of their patients. Thus, the American Society of Hematology has taken a very bold effort to develop guidelines across the spectrum of different clinical situations where venous thromboembolism becomes a major problem. It's well known that DVT and PE are potentially devastating complications that may occur following major surgical procedures, and there are some prophylactic measures in place for decades now. But even with the prophylactic measures, surgery accounts for around 25% of venous thromboembolism cases observed in the community. Statistics suggest that around 60,000 to 100,000 Americans die of venous thromboembolism every year. There are more deaths of venous thromboembolism than AIDS and breast cancer combined. Another thing is that venous thromboembolism is a very important area for the development of evidence-based guidelines, especially that it's a disease that affects people with an underlying disease already, like cancer, for example, and it's impossible to keep up with the field when it's moving so quickly. So as we can see in here, the target audience for these guidelines are patients, surgeons, intensivists, internists, hematologists, pediatricians, and many others down the line.
Dr. Malaz. Okay, now it's working.
Yes.
The screen
Is
was
there a problem?
lagging. The screen was lagging behind.
Okay. So our next question is that how were these ASH guidelines developed? Firstly, a panel was created, and the presence of expertise balance was very essential. Thus, the panel included surgeons with subspecialty representations, hematologists, internists, and a pharmacist, all of whom had clinical and research expertise on the guideline topic. It also included methodologists with expertise in evidence appraisal and guideline development, and 2 patient representatives. Another important aspect is how was the conflict of interest managed throughout the process. And there is a detailed description for this in the paper. I'm not going to be able to go over all of the details, but if you are interested, you can surely check the paper for the details. Now, mainly to manage the conflict of interest, the guidelines were entirely funded by the ASH, a nonprofit organization for hematologists. And while some panel members were also part of the ASH, the staff at the ASH only helped with organizing meetings and appointments. They had no influence on choosing the guideline topic or recommendations. Another thing to manage the conflict of interest, the panel members had to disclose any financial or personal interest before being appointed. If any member had a financial interest in a company that would be affected by the guidelines, they were excluded from voting on these topics. They could still discuss the evidence, but they did not make final decisions on those issues. Most importantly, that the process followed ASH policies, which was based on guidelines from reputable organizations like the Institute of Medicine and the Guideline International Network. The next step was to formulate specific clinical questions and determining the outcome of interest. So they formulated these questions following the PICO format. For example, we go for pharmacological prophylaxis versus mechanical prophylaxis, or mechanical prophylaxis versus no prophylaxis, and so on. For the outcome, they were very selective. They used only the outcomes that were regarded as a major problem, like mortality and major bleeding, for example. And we're going to go over these in a few. Regarding the evidence synthesis, when evidence summary was generated for each question, they followed a step-by-step tool to make solid evidence-based decisions. This tool is called the grade evidence to decision. It's like a checklist or a table that addresses certain factors, namely, the first one is resource use. Is it cost effective? That's the question here, in the sense that even a great treatment can be impractical if it's too expensive for hospitals or individuals to use. The next one is feasibility. And why does it matter? Because a guideline should work not just in theory, but also in clinics, hospitals, and different settings. For acceptability, it's another important criteria to consider, in the sense that are doctors and patients willing to follow the recommendations? For example, some doctors might be hesitant to prescribe direct oral anticoagulants if they are skeptical about bleeding. The recommendations also have to be equitable. They should be fair and work for everybody, not just the privileged populations. And finally, the guidelines should match what people value in real life, not just what shows up in the data. All right, so how patients and clinicians, how should they use these recommendations? All right, so when the panel makes a recommendation, they tell how much confident they are that most patients should follow this recommendation. So we have, as we can see here, strong recommendation or conditional recommendation. A strong recommendation basically is the best choice for everyone. For patients, almost everyone in this situation would want to follow this advice, and only a few people might choose something different. For clinicians, a strong recommendation means that you should strongly recommend this treatment to your patient. You don't need any sort of decision-making tool. It's usually obvious and straightforward and widely accepted. A conditional recommendation could be a good one, but it depends on the person. For patients, most would go with this intervention, but a lot would not. Particularly in this case, decision-making tools like charts or checklists may be used to guide patient preference. For clinicians, there is no one-size-fits-all answer in here. You should talk to the patient about what matters to them. All right, as we know, and as I previously mentioned, that venous thromboembolism is very common following major surgery. It accounts for 25% of venous thromboembolism cases in the community, and it might cause over 50,000 deaths annually in the United States. Also, the risk of post-operative venous thromboembolism risk like it varies based on the procedure. So there might be high risk in joint arthroplasty, neurosurgery, vascular surgery, but it might be low risk for another type of surgery. And venous thromboembolism after surgery often occurs after hospital discharge, especially when you would have to discharge the patient within a couple of hours or like a few days. So in this chapter, we're going to focus on two patient groups. The first one is major surgical procedures, those who underwent a major surgical procedure like cancer and non-cancer related procedures equally are going to be addressed in here. And the other group is patients who got hospitalized for major trauma, regardless of whether they underwent surgical procedures or not. Also, there are two types of modalities, pharmacologic prophylaxis and mechanical prophylaxis. For the pharmacologic prophylaxis, it includes anticoagulants or antiplatelet agents like aspirin. And for the mechanical prophylaxis, it includes graduated compression stockings, intermittent pneumatic compression devices, and inferior vena cava filters. So our next question is, what type of clinical outcomes were considered critical by the panel while making decision making? So they focused on important outcomes like mortality, symptomatic PEs, symptomatic proximal DVTs, major bleeding, and reoperation. And they specifically considered that symptomatic proximal DVTs and PEs were clinically significant if confirmed by imaging. And the panel rated proximal DVTs and PEs as moderate severity if they were confirmed by objective tests, which means that these conditions are serious enough to matter in clinical decision making. They did not consider asymptomatic events as critical unless they led to symptoms later on. So for some studies, they did not distinguish when reporting these studies in general. They did not distinguish between symptomatic and asymptomatic events. And in this case, they used estimates to model how many asymptomatic events would likely turn into symptomatic ones later on. All right, for the structure of the guidelines, basically, some recommendations are specific to certain surgeries. For example, deciding between medication or no medication or what kind of medication to use. Other recommendations are broad and they apply to any major surgery. For example, deciding whether to use drugs or mechanical devices, how long to use the drug, and when to start them. For the first one, it's a strong recommendation, and the other one is a conditional recommendation. So to go over like the recommendations and try to make sense out of them, we're going to follow a case scenario-based discussion in here. And our first patient is a 69-year-old male who has diabetes, hypertension, and osteoarthritis. He's currently on metformin, ramipril, and Lasix. As for the surgical history, elective total hip arthroplasty was done yesterday under spinal anesthesia, and the estimated blood loss was 100 cc. The surgical site looks clean and dry today. So the first question is, your patient is post-operative, day 1. Sorry. Yeah, so post-operative day 1, following an elective total hip arthroplasty, he had no preoperative prophylaxis of thrombosis and is on no regular antithrombotic therapy. What would you recommend today for post-operative VTE prophylaxis? And the answer is, we can go either with aspirin or direct oral anticoagulant over low molecular weight heparin or unfractionated heparin or warfarin. So let's try to understand, why did we go for aspirin and direct oral anticoagulants? And the reason behind this is that for patients undergoing total hip arthroplasty or total knee arthroplasty, the panel suggests using either aspirin or anticoagulants. And as it's stated that there is a very low certainty, and this is a conditional recommendation. Now, why is that? If we look in here, we have different outcomes like mortality, symptomatic PE, symptomatic proximal DVT, and major bleeding. And if we look at the relative risk, all of these, they include 1 as a value. So statistically speaking, they are not statistically significant, none of them. That's why it does not matter if we go for aspirin or a direct, like an anticoagulant in general. They both work the same way. There is no any sort of evidence suggesting that like there is a benefit of using one over the other. All right. So for patients undergoing total hip arthroplasty, as we said, taking where anticoagulants or aspirin, like where anticoagulants are going to be used, the panel suggests that we should go with direct oral anticoagulation over low molecular weight heparin. And as we can see here, for all of the other outcomes, they're not statistically significant except for this one. If we look at the relative risk, it does not include 1, the confidence interval, meaning that it's statistically significant, and there is an actual benefit of using direct anticoagulation therapy over low molecular weight heparin when it comes to symptomatic proximal DVT. So this is to answer the question that, let's say we went with anticoagulants, should we go for direct oral anticoagulant or low molecular weight heparin? The next question is, if we decide to use an anticoagulant, any of the approved direct oral anticoagulants is reasonable. Okay, I did not miss something in here, right? All right, the next question is, let's say we're going to use a direct oral anticoagulant. Should we start it early or like, meaning that in less than 12 hours or after like 12 hours? Is it early, like, should we go with the early option or delayed option? And regarding this, there is no specific recommendation suggesting like a stronger benefit of any of these. You can go with either options. as we see in here, also the confidence interval is not statistically significant. All right, so after that, we decided that we're going to go for the we're going to start the anticoagulant early on. Now the question is, should we use them like for an extended period of time or just a short period of time? And here the panel suggests or strongly recommends that we use them for an extended duration. Actually, sorry for that. It's a moderate evidence, not strong recommendation. As we can see here for the outcomes, symptomatic PE and symptomatic proximal DVT, they are both statistically significant, and there is a real benefit of using direct oral anticoagulants for a short-term period. I mean, like for an extended period, sorry. And just to wrap up this case, your patient is discharged on a low-dose direct oral anticoagulation for 5 weeks, which is an extended period. He is seen in the follow-up by his surgeon at 5 weeks, and he's doing well with no other complications. Thank you for listening to the case. Now, Dr. Rana is going to go over the next slide, the other cases. And please, if you have any questions, you can ask me at the end of the session.
Hello. Thank you, Dr. Malaz. That was a very informative part on your behalf. Thank you, everyone, for being a part of this meeting. And we just have 2 more cases left to discuss. I'll pick up where Malaz left off by talking about trauma patients and how can we prophylax them for VTE or venous thromboembolism. So the second case, it's a trauma case. So we have a 74-year-old female. She fell down the stairs and hit her head. She's diabetic and hypertensive. She takes antidiabetics and hypertensive medications. They did a CT scan and it showed moderate subdural hemorrhage with mild mass effect. So she had no neurological deficits and she had normal mental status and was hemodynamically stable. So they admitted her to the trauma ICU for observation with no plans for surgical intervention. And then later on, this patient was admitted with moderate size, the subdural hemorrhage increased in size, the moderate size subdural hemorrhage in the CCU. And the neurosurgical team, they felt or they feel that she is at a high risk of bleeding or she has a high bleeding risk. But they don't plan to do any surgery. So the question is, what would you recommend for thromboprophylaxis at this juncture or at this time? And I'd love for this session to be interactive, but because we are a little short on time, I'm hoping everyone went for the answer mechanical prophylaxis only from the options. So the reason why we're going for mechanical prophylaxis is because she's a high bleeding risk. And the panel, when they went through the different studies, observational and RCT studies, they found that they, based on their recommendation was that it's based on the risk of bleeding that the patient is currently in. So if the patient had a major trauma and she is a low to moderate risk of bleeding, the panel suggested that we go for pharmacological prophylaxis. However, if there's a high risk of bleeding, then they suggested against pharmacological prophylaxis. Again, this is a conditional recommendation with very low certainty, meaning that the benefits could or could not with low certainty outweigh the risks, so they do need more research, and with more researches, the recommendations can change. So here we have a comparison in the outcomes between pharmacologic and non-pharmacologic prophylaxis or no pharmacologic prophylaxis. And we can see here that the outcomes for PE, symptomatic PE and symptomatic proximal DVT, not only were they statistically significant, but we can see that it could reduce the occurrence of the PE and the DVT. So if the patient is, again, low risk or moderate risk of bleeding, we would want to go for pharmacologic prophylaxis. That's what they're saying here. But again, since this patient was a high risk bleeder or of bleeding, it's important that as clinicians, we reevaluate the bleeding risk periodically as the patient recovers in the trauma CCU unit. So again, trauma patients, if this patient, we weren't able to give her pharmacological prophylaxis, we do want to give them mechanical prophylaxis. And yes, the recommendations were that if the patient did undergo, or if the patients are undergoing major surgery, and we cannot give them pharmacologic prophylaxis for certain contraindications, they suggested that we do use mechanical prophylaxis over no mechanical prophylaxis. And this applies not only to major surgical candidate patients, but also trauma patients in the context. And again, of course, we know traumas are of different types in different areas of the body. But again, if there's no specific contraindication to using mechanical prophylaxis, such as lower limb injuries, then we can go for it. That is, if you can't use pharmacological prophylaxis. Okay, so moving forward, 72 hours later, the patient remains stable and there are no changes in her head CT scan. She is still in the ICU and has limited mobility. So the neurosurgical team feels she can receive pharmacologic prophylaxis safely now. There's new clinical data that was added to the patient's file by the neurosurgical team. And now the question is, what would you recommend at this juncture or this time? Do we continue giving her mechanical prophylaxis alone, or do we want to give her low molecular weight heparin or unfractionated heparin, or do we want to go for inferior vena cava filter insertion? And I hope everyone here is thinking of switching her to pharmacologic prophylaxis, respecting the neurosurgical team's opinion. So we can go for either low molecular or unfractionated heparin. Now, the panel did look into the evidence that they used to formulate this guideline, and that they found that you can use either low molecular or unfractionated heparin. Of course, the differences in the outcomes between these two agents was not very statistically significant. Not only that, but it wasn't much of a big difference. So, and then again, when you do want to choose between low molecular weight heparin and unfractionated heparin, you do want to look at the complications that can arise from either agents, right? As well as the morbidities that the patient can present with. So if the patient, for example, for instance, has CKD, we do want to look into giving her unfractionated heparin, even if we are going to be monitoring her constantly. And again, you can choose either, but the panel did favor low molecular weight heparin over unfractionated heparin in general, so to speak, as a net benefit. So in conclusion, the patient was started on low molecular weight heparin for the VTE or venous thromboembolism prophylaxis. There was no signs of recurrent bleeding, and she was discharged with a stable condition, and eventually she was put for rehabilitation. So this was the trauma aspect, like how do we deal with VTE prophylaxis in trauma patients in general, whether they do need surgery or not. The next case, which will be the final case, is in terms of neurosurgery. And so neurosurgery is, as Dr. Malaz mentioned earlier, considered a high-risk surgery for VTE based on the evidence and the research. So they do want to know how to approach such a case. So we have a 35-year-old female. She has a meningioma 4x4. She's healthy. She doesn't take any medications, and she was admitted for neurosurgical resection of this tumor, which was successful, and she was admitted to the post-op neurosurgical wards. And you can see here that she is able to ambulate. So she's mobile, she's able to move and walk to the bathroom independently. You're seeing this patient on post-operative day 1 following her meningioma resection. She is ambulating and is expected to stay in the hospital for the next 5 to 7 days while she recovers. She has no prior history of thrombosis, so she's healthy and she's ambulating. What should she receive for post-operative VTE prophylaxis? And the answer here would be no, pharmacologic prophylaxis. So they did recommend against the use of pharmacologic prophylaxis in major neurosurgical procedures. And when they did compare the outcomes between pharmacologic and non-pharmacologic prophylaxis, they found that the main reason why we would want to avoid using pharmacologics is the risk of major bleeds. And although it is statistically insignificant, it is clinically significant. And it's been seen that you could get 10 more bleeds per 1,000 patients. And so to be on the safer side, they went for this suggestion. Again, this is conditional recommendation, and with further studies, this could change. But for now, they recommend against using pharmacological prophylaxis. So, of course, we need to know that even if we are not going to be giving them pharmacologic prophylaxis, we do still want to give them mechanical prophylaxis, okay? Most patients nowadays admitted to stay in the hospital are given mechanical prophylaxis or pharmacologic prophylaxis. So we do want to give them mechanical prophylaxis. So to emphasize or to go through what I've been saying earlier just now is that the reason why it's not routinely recommended again is because the pharmacological prophylaxis benefit after neurosurgical procedures is actually likely small. And the studies that were in favor of pharmacologic prophylaxis were usually observational data or studies in comparison to the randomized clinical trial data, which suggested that there wasn't, it was low risk of VTE in patients post-op from neurosurgical procedures. And so even then, the benefits of pharmacologic prophylaxis often seen in asymptomatic DVT using screening venography, which may not be as clinically important. Again, there are harms of major bleeds from pharmacologic prophylaxis are moderate due to greater potential for morbidity from the surgical site. So we want to avoid bleeds, like I've mentioned earlier. And since we have a more safer approach or thing to do to keep the patients from getting a VTE, we would go for it. And this would be the mechanical prophylaxis. Okay, we have another patient here. You're seeing another patient on the same day who also has a meningioma resection the day before, or had a meningioma resection the day before. So this patient that we're seeing currently is a different patient, and 78-year-old patient who has obesity and Parkinson's disease, and he's expected to stay the same amount of time the other patient is staying, 5 to 7 days. post-operatively, and he has limited mobility. So what would we suggest to give as post-op VTE prophylaxis? Now, the question here, the answer would be to either not give pharmacologic prophylaxis or to give low molecular weight heparin or prophylaxis pharmacologic. And the reason is that it is based on the case. So it's a clinical judgment-based decision because there is very low certainty in the evidence for us to direct a recommendation here, or the ASH to direct a recommendation in the guideline in regards to this matter. So it's based on the patient. And again, you may consider pharmacologic prophylaxis if the patient, for example, is at a higher risk of thrombosis, such as patients who are going to have a prolonged immobility after surgery, or patients who don't have or have a low risk of major bleeding after surgery, as well as if the patient will not be immobile for a long period of time after surgery. So you consider the risks and the benefits as a doctor, and you make the decision based on that. So a recommendation is that for a subset of patients undergoing major neurosurgical procedures for whom pharmacologic prophylaxis is used, the panel suggests using LMH, low molecular weight heparin or unfractionated heparin. Again, this is, you can use, you have to, they've seen that it's better to use low molecular weight heparin over unfractionated heparin in the cases of major neurosurgical procedures. Again, this is low certainty. It's just a net benefit, like I've mentioned earlier, that we would use low molecular weight heparin over unfractionated heparin in general. So what about using IVC filters? We do see them used, right? So what about using them? Well, the recommendation suggests against using IVC filters, in fact. And this is because if you look here, out of all the outcomes that compare using IVC filters to no IVC filters, under symptomatic proximal DVT, you can see that it's statistically significant and that the risk of using IVC filters gives you a chance of getting 31 more DVTs per 1,000 patients. And this translates to having more risk of getting DVT in a patient put on IVC filter rather than given mechanical prophylaxis or pharmacologic prophylaxis. And so the high rates of DVT and the trend towards higher mortality with filters outweighs the potential risks or reductions in the risk of PE. And not only that, but we can't forget that there is potential harms from filter insertion, like IVC perforations or filter embolizations. And although the panel did not go over these potential harms, this is something to look into or look out to when speaking of IVC filters. So should the patient also receive mechanical prophylaxis on top of the pharmacologic prophylaxis? Well, yes, the panel did suggest the use of combined prophylaxis, again, with conditional recommendation and low certainty. But when using combined prophylaxis, mechanical and pharmacologic, they did say that especially for people with high risk of VTE, like people who are obese or people who have clotting problems, right, diseases. So especially in them, it would particularly work in their favor if we use both mechanical and pharmacologic prophylaxis. And they did see that it may reduce the risk of PE with a statistical significance when you combine them both. But the panel did not assess the potential drawbacks of using mechanical prophylaxis, which could be patients falling after while using them, or skin complications like pressure ulcers or necrosis or such. which should be measured with more research. And again, the other recommendation is that when you do want to go for mechanical prophylaxis, it's best to use intermittent pneumatic compression devices over graduated compression stockings. They did see that while there's no difference in the outcome of symptomatic PE, there was or there may be a reduced risk of symptomatic DVT with pneumatic compression device that was statistically significant, so to speak. So, and again, if the hospital you work in does not provide pneumatic compression devices, you would still want to go for graduated compression stockings. So in conclusion, the first patient, the healthy one, she received graduated compression stockings because we did not have pneumatic compression devices. And she did not get any pharmacologic prophylaxis and was discharged on the encouragement to ambulate more. And while the second patient, the 78-year-old immobile patient, received the combination of both mechanical and pharmacologic prophylaxis and did not experience any bleeding or thrombotic complications and was discharged for rehabilitation after 8 days in the hospital. Here is a compelling list of other procedure-specific recommendations from surgical type, the panel suggestions, and the rationale behind it. And we can see that if for every surgery, there's a different recommendation for how to prophylax against VTE. For instance, in hip fracture repair, they did recommend or suggest pharmacologic prophylaxis over not using pharmacologic prophylaxis. And this could be either low molecular weight heparin or unfractionated heparin. As in major general surgeries as well, this recommendation was followed. But for example, here in laparoscopic cholecystectomy, the panel suggested against the use of pharmacologic prophylaxis. And it depends on the patient. Again, it's a clinical-based judgment, case-to-case differs. And then we have cardiac and vascular surgery. You can either go for pharmacologic or non-pharmacologic prophylaxis, and the same applies. It's a clinical-based judgment decision to make. Gynecologic surgery, they recommended pharmacologic prophylaxis over non-pharmacologic prophylaxis. And for prostate surgeries, transurethral resection of prostate and radical prostatectomy, both surgeries, the panel suggested against the use of pharmacologic prophylaxis. Here is a list of the identified areas of future investigations, some of which are currently under further study already, with more evidence being released every day to update and enhance the guidelines towards a better and more strategical approach to preventing VTEs in patients. So some examples of the areas that were identified for further investigations would be the benefit of combined prophylaxis compared with pharmacologics alone, extended prophylaxis outside of orthopedics and cancer surgery, optimal duration of extended pharmacologic prophylaxis, the timing of initiating prophylaxis in higher risk bleeding procedures, comparison of different prophylaxis strategies for hip fracture surgery specifically, and benefits and risks of pharmacologic prophylaxis after neurosurgery using clinically important endpoints. And finally, the use of delayed pharmacologic prophylaxis in trauma patients with major bleedings, including intracranial hemorrhage. So these are all areas that are being studied, like I said, and they're looking into them. So I think this would be the end of our presentation. I hope you all came out of it with more information and it benefited you. So thank you for hearing us out. And I'll give the mic back to the moderator.
Thank you, Dr. Rana. Thank you, Dr. Malaz. It was very wonderful. Back to Dr. Nader.
Thank you so much. Great presentation, everyone. Any questions for any of the presenters? Great job. Any updates? Dr. Nadine, are you ready?
Hello, yes, of course I'm ready. First of all, I just want to say thank you so much, Doctor, for this opportunity. So what we're going to do today, first let me share my screen. So I hope my screen is clear for everyone and the sound is okay. You
Yes.
guys, okay. So my idea is to start a case-based learning series where every Saturday I'm going to be talking about a different topic in geriatrics, but in clinical case scenarios. I personally prefer this type of learning and this type of teaching. I find it to be more interactive, and it simplifies a very common and sometimes complicated topics in geriatrics in a very beautiful and a way that's going to be stuck with you in your clinical practice, I hope. And today I wanted to start with the very common topics, and there's some topics that are commonly confused because of the similarity in the name, which is delirium, dementia, and I'm going to be touching upon a normal aging process. So I named this presentation of today and our case for today, the Forgetful Grandpa, where I'm going to be evaluating memory loss in the elderly. I hope this is going to be a very interactive session. So I hope for everyone to feel free to open the mic or insert the answers for some of the questions that are going to follow the case that I'm going to read in the chat box. So our first case, the title is He's Not Confused, He's Just Tired. A missed delirium in an elderly man with a known case of Alzheimer or dementia. So our patient for today is Mr. Sanim, a 78-year-old man with a history of a well-controlled hypertension and early stage Alzheimer's disease. He's admitted to the hospital for a UTI. On day 3, he becomes agitated, tries to get out of bed and shout at the nurse. He doesn't recognize his daughter and keeps insisting that he has to go out and catch the bus. The night nurses write in the chart, patient confused, likely dementia. His daughter insists that this is not like him. Even with dementia, he always knows me. So first thing I want to touch upon in this case with our patient, we're going to talk about the clinical reasoning in this case. So the first question, has any of you guys noticed a red flag in this case? Anything that caught your attention? If you guys can share, or if you guys want to open the mic and talk. So first, red flag that is important in this case is the sudden changes in behavior or in cognition. So our patient here has been hospitalized for a UTI, and within a couple of days, or on the day 3 of his hospitalization, his condition deteriorates and he has behavioral changes. He becomes more agitated and having hallucinations. So what is catching our attention here is the fluctuating mental status. Like before, he used to be fine, but now on day 3 of hospitalization, he's become more confused and agitated. A very important and key point to touch upon is the family and the caregiver concern. In the line where the daughter insists that this is not like him, even with dementia, he always knows me. So this is a very important point to mention. A very important red flag in this case is the family and the caregiver concern. So sudden changes here suggests delirium and not dementia. Even though the patient is already diagnosed with an early stage Alzheimer, this shouldn't carry the diagnosis away or causes a premature closure of the diagnosis and just label him as dementia. as the nurse did. She wrote down patient confused, likely dementia. So these are the main red flags in this case. So, and how can we, and as I mentioned, this is dementia and not delirium. So how can we know actually the difference between dementia and delirium? Well, it's very basic and very simple. If we talk about delirium, we're talking about something that is acute, like this patient. It happens within hours or days. While dementia, it is insidious onset. The course is more gradual over months and years. The delirium course is fluctuating, while the dementia is progressive and stable. The reversibility of the case, the delirium is usually reversible. If you actually identify the underlying cause, most cases of the delirium are reversible, while dementia is an irreversible case. In delirium, hallucinations are very common, while in dementia, you can see a hallucination in dementia, but it's rare unless it's Lewy body dementia. So you can use tools like confusion assessment method, CAM method, to actually assess your patient. So what are the, as I've mentioned, while differentiating dementia and delirium, you can, if the cause is known, delirium in most cases is reversible. So how can we know the reversible causes of delirium? Well, that's very simple because we have a mnemonic, which is called pinch me. So you can start with P, which resembles pain. I, infection, like in our patient, it's UTI, or it could be like in other patients, pneumonia. Nutrition, patient could be dehydrated or having some deficiencies in vitamins like B12. C, it's constipation. H, hypoxia and hypoglycemia. M, medications, which is anticholinergic or like benzos. And E, environment, which is sleep disturbances and unfamiliar settings, like our patients in the hospital setting. So it's often multifactorial, the causes of delirium, but it's often reversible once the underlying cause is identified. For our patients, we can go ahead and ask for workup and investigations. We can start as simple as CBC to monitor his infection, and urine analysis and culture to monitor infection and the resolution of the infection. We can simply look for the other reversible causes, which is electrolytes, glucose, any minerals deficiencies or vitamin deficiencies like B12, folate. We can ask for renal and liver function test. If we're suspecting pneumonia, we can go ahead and ask for chest X-ray. And most importantly, and sometimes it is forgotten to do, is to review the medication list, which is very important because I've mentioned before, a lot of medication, especially in the hospital setting, a lot of anticholinergics and benzodiazepines would be the precipitating cause of delirium. Okay, so what are, and after we've ordered the investigation, what are the non-pharmacologic interventions that we can go ahead and go for first, either to prevent or to manage delirium? So it could be as simple as reorientation, having a clock in the room of the patient, opening the windows at the daytime to make the sun goes into the room, the presence of a family member, mobilization, which is very important, early ambulation for the elderly patients, avoid restraints and sedatives, ensure good hydration, nutrition, and pain control. Those are all the non-pharmacologic, and non-pharmacologic strategies are key because sometimes they work even better than the medications. So this brings me to the topic of haloperidol, which is a common drug that we know that can be used in the acute setting of delirium. But when, if ever, this medication can be used? So the haloperidol is used in very rare cases, only if the severe agitation threatens the patient or the staff safety. And if we went ahead and we used the non-pharmacologic interventions prior, but the patient shows no improvement. So if the non-pharmacologic measures have failed, we can use a low dose and a short duration of haloperidol, which is 0.5 milligram. We can use it orally or IV. But one important thing is we should always avoid benzodiazepine unless the patient is in alcohol or sedative withdrawal. A very important angle and aspect in our case is the ethical angle. So what role does the caregiver's input play in the clinical judgment? So when the doctor said that the patient is not like that, even with dementia, he remembers me, that's a very important clue, and it's a very critical point in the history because it provides the baseline insight and early recognition of abnormal behavior, which helps avoid mislabeling delirium as dementia. So you should always validate family concern and build trust, because sometimes ignoring the caregiver may lead to delayed diagnosis and harm the patient. So how can we avoid that ageism and cognitive bias in patient care? It's as simple as that. You don't assume all confusions equals dementia, especially if a patient is already diagnosed with, as like this patient, Alzheimer's disease. So don't confuse confusion equals dementia. That's not correct. You should take every behavioral change seriously. You should listen to the caregiver and the family, take a very good history, and check your own biases. Older adults deserve full workups and respect. And never forget to check the reversible cause that I've mentioned. So the main key takeaways is number one, delirium is a medical emergency. It has an acute onset, fluctuates, and usually reversible. Number two, always listen to the caregiver. They know the patient's baseline best. Their concerns are often the first clue. Number three, don't dismiss the new confusion as just dementia, just like the nurse did. So sudden changes in behavior in a non-dementia patient are not normal and need evaluation. Number four, you should check for the reversible cause and in the pinch me mnemonic, which is pain, infection, nutrition. Number five, prevention is key. Reorient the patient, minimize the noise, encourage mobilization, and avoid unnecessary medications. Number six, medication is the last resort. Just like I've mentioned, haloperidol, only if the patient is in danger to himself or the others. Number seven, delirium worsens outcome if missed, leads to longer hospital stays and increased mortality and caregiver burden. That shows how important good history taking is and catching the delirium in the early stages. Number eight, be aware of ageism and bias. Older adults deserve full medical assessment and not just assumptions. So this is our first case, which clearly shows the difference between dementia and delirium. So now a very important case now, which shows normal aging and understanding the normal cognitive agent. So the case is titled as "You're Still Sharp, but a Little Slower." So the case vignette and our patient for today is Amina, a 76-year-old retired school principal, comes to the clinic with her grandson. She said she's a little worried because she forgets names and sometimes and occasionally walks into a room and forgets why. Her grandson adds, she forgets where she parked her car last week, but she still cooks and manages her finances and play cards weekly with friends. She's not depressed and there is no family history of dementia. So again, we're going to start with clinical reasoning. What are the typical signs of normal aging? So a lot of typical signs of normal aging has already been mentioned in the case, which is a mild forgetfulness, which is like forgetting where you put your items, misplacing items. Slower recall, which is mentioned in the title of this case. It just takes longer for you to remember names, for example. Mildly reduced multitasking ability. But most importantly, the most typical sign for a normal aging is a preserved function, and the function is intact, and there's no impact on daily living. This is a very important sign in distinguishing, is this normal aging or not? What are the red flags that might not be normal aging? Red flags is getting lost in familiar places, repeating questions frequently, trouble managing finances or medication, personality change and lack of insight, and impact on job, safety, and social life. So any advice and reassurance that you can give for this patient, because this is clearly a case of normal aging, because here it says that the patient is doing well otherwise, and she herself comes complaining of having memory issues, and this is an important clue that this is a normal aging. Another important clue is that she's doing otherwise very well. Her function is intact. So any reassurance, you could just simply start by saying, or by telling your grandson or the patient herself that these are mild changes and they are expected with age. You should encourage the brain health by encouraging the patient to exercise, doing social activity, mental stimulations, and healthy sleep. And tell her to monitor for changes and ask her for regular check-ins because they are quite helpful for these old patients. Stay engaged in life routines and hobbies. So main takeaways is number one, mild memory changes are a part of normal aging. The brain slows down but does not stop working. Functional independence is the dividing line. This is very important because otherwise they're functioning normally. Not all forgetfulness is dementia. Reassurance without dismissing. You should educate the patient on when to follow up. And most importantly, lifestyle intervention and promote brain health proactively. And because this can help decline and delay the decline in function even in normal aging. A very beautiful quote that I came across, it says, "Aging is the life most persistent teacher." It is by Dr. Lewis. He's a geriatrician and the author of Elderhood. So this line beautifully captures the idea that aging teaches us lessons no other life phase can, about resilience, patience, humility, and letting go. It reminds us that growing older is not a decline, but it's an ongoing process of learning, even if the lessons are hard. So the body may slow down, but the opportunity for growth, insight, and reflection continues. This brings me to the end of my presentation. I just want to say thank you so much for your time and thank you for listening. If you have any suggestions or thoughts about how I presented the case and how I led the discussion, I would love to hear some feedback, maybe from Dr. Nader and everyone who've been a part of this session. So thank you so much.
Great presentation, great cases, wonderful. Any questions or any comments in addition? Thank you so much, Dr. Nadine. Any other ideas for the program itself, new research project, questions about the program itself? Any updates? If not, I'd like to thank you all for attending this program or this meeting. And I'd like to thank Dr. Shumaila and her team for great presentation, wonderful and great presentation. Hopefully this will be very helpful to you guys. And thank you to Dr. Nadine and Dr. Sulafa for sharing. We'll see you next week, inshallah. If you have questions, please let me know. Contact me via email, call me or text me. I'll be happy to help as much as we can. Have a wonderful day or night. See you next week. Assalamu alaikum.
Thank you, Dr. Nader. Thank you. Assalamu alaikum. Wa alaikum assalam.
Thank you, Dr. Nader.
Thank you, everyone.